Hello everyone, I hope everybody is preparing very well for the upcoming exam. It is a very pity what has happened in the RG Medical College. In the land where we worship many women goddesses is the same land where they are undergoing lots of sufferings. Hospital, so-called the temple, has turned into a graveyard. It is our responsibility now to stand together and fight for the justice of our beloved colleague, and let's all stay together and make sure that such a nuisance is never going to happen in the country. Let's step forward and try to make sure that we all are there to make our society a better place to live. In anatomy, we are going to revise embryology. We'll be also revising the upper limb and also the lower limb. This is Dr. Auroraj, and now let's get started with our anatomy lectures. Gametogenesis is the process of forming gametes, the process of forming mature germ cells. Yes, the female gamete is called as oocyte. It undergoes a process, oogenesis. The male gamete, which is called as spermatozoite, undergoes spermatogenesis. Yes, the female gamete, which is called as oocyte, undergoes oogenesis, and the male gamete, which is called as spermatozoite, undergoes spermatogenesis. Since school days, we all know that the number of chromosomes in normal human being is going to be 46 diploid. It is either 46XY for male or 46XX for female. Yes. During gametogenesis, during this process, what happens is that the number of chromosomes become haploid. It becomes 23. Very important to remember. Now, the primitive streak, it gets converted into FMGE, which is called as primordial germ cells, in 2 weeks, and then it migrates to the wall of the yolk sac. At the 5th week, goes to the genital ridge, forming either testis or ovary. It's very important. Gametogenesis. Spermatogenesis. It happens in the testis. Here, this is the image of testis. Here we can see the epididymis, and then classically also the seminiferous tubules. Now, when we enlarge this image over here, this is how it looks like. Let's start. What are the processes happening in spermatogenesis? The primordial germ cell gets converted into spermatogonium. From spermatogonium, it further undergoes mitotic divisions and comes the primary spermatocyte. So first spermatogonium, primary spermatocyte, and then we have secondary spermatocyte. Followed by other meiotic divisions, there will be spermatids, and at the end we are going to have what? Mature sperms. Let's repeat the process once again. Spermatogonium, primary spermatocyte, secondary spermatocyte, and then we are going to have spermatids, and at last the mature sperm. Very good. Now look at the process here. Spermiogenesis. The conversion of spermatids into mature sperm or spermatozoa is called as what? Spermiogenesis. Spermiogenesis. Good. Spermiation is the release of spermatozoa to the seminiferous tubule. Both the process name has to be remembered for the exam. What are the other important points? The site. Where it happens, sir? It happens in the seminiferous tubules. Very important. Duration is going to be 72 to 74 hours. One spermatogonium is going to have 64 spermatozoa, mature sperms, and epididymis, this region right over here, this is going to be the storage and maturity, along with that motility of the sperm. Very important. Oogenesis. Female gamete, oocyte, undergoes oogenesis. Now the primordial germ cells becomes what? Oogonium. Since school days, we have been studying about mitosis and meiosis. Meiosis happens in the reproductive cells. Yes, there is going to be meiosis 1 and also meiosis 2. Good. Now we also need to remember the prophase, metaphase anaphase and telophase 1 and 2. Yes. Now this primary oocyte undergoes meiosis 1. What happens is that the primary oocyte gets arrested in meiosis 1 of prophase at the diplotin stage. Very important. Before birth, the primary oocyte gets arrested in the diplotin stage of prophase 1 in meiosis. Very important. Then what happens is at the puberty, now the child has attained puberty. What happens there? The LH surge happens 36 hours prior ovulation. Meiosis 1 gets completed with the release of a secondary oocyte, and along with that first polar body. You can see first polar body here as well. Yes, very important, remember. And then the secondary oocyte enters meiosis 2, and again it is arrested in metaphase 2 of meiosis. Very important again to remember. So the secondary oocyte gets arrested in metaphase 2 of meiosis 2. Very good. And then meiosis 2 only gets completes when fertilization happens. When the fertilization happens. Yes, this is the process of oogenesis. Now the ovum is fertilized, a sperm is penetrated into the ovum, and now it undergoes the process called as fertilization. Let's see what happens right from day 1. Now day 1, zygote gets formed. Yes, zygote gets formed, as you can see here, and then it forms a layer which you can see it yellowish here. This is called as zona pellucida. The yellow region, however, is called as zona pellucida. It prevents polyspermy and also ectopic pregnancy. Once again repeat, polyspermy and also ectopic pregnancy. Very good. This one here prevents ectopic pregnancy. Good. Day 4, blastocyst gets formed. Very good. And at day 6, implantation happens. It starts and gets completed by day 10. Very important. Now, where does the site of implantation happen, sir? It happens at the junction of the fundus of the uterus on the posterior wall. Junction of the fundus of the uterus in the posterior wall. That is where the implantation happens. Good. Now, implantation is completed. Let's see what happens in the second week, which is called as bilaminar germ disc formation. The outer cell mass, which you can see here, this is called as trophoplast. Yes, this outer cell mass forms the trophoplast. Question 1 to remember. Epiplast, this region here, epiblast, is actually formed by the inner cell mass. The inner cell mass forms the epiplast. Yes, these are formed by the inner cell mass, which is also called as primitive ectoderm. Primitive ectoderm, yes. The hypoblast, the middle layer, is formed by one layer of the inner mass. Yes. So by now you should be able to remember trophoblast, epiblast, and also hypoblast. Next, the Husser's membrane and the hypoblast forms the yolk sac. This is also another important point. Remember, which forms the yolk sac? It is the Husser's membrane and the hypoblast. Good. Next, here we can see the yolk sac. The splanchnopuric extra embryonic mesoderm presents around the yolk sac. Yes, these are going to be these layers here. This is going to be present around the yolk sac. It is called as extra embryonic membranes. Good. Let's enter into third week, which is called as gastrulation. The epiblast and the hypoblast, they move forward. The hypoblast, as they move forward, it forms procaudal plate. Very important. Procaudal plate makes the craniocaudal axis of the embryo. Very important. Once again I repeat, procaudal plate makes the craniocaudal axis of the embryo. Next, the primitive streak forms 3 germ cell layers. First is going to be endoderm, mesoderm, and ectoderm. I repeat, it first is going to be endo, meso, and ecto. And then the primitive knot actually forms the notochord. Endodome is going to be the first layer to be formed. These are the important points. Now look at the image over here. This is going to be what? The epidermis. And here we have the endodome. This is going to be the endodome. This is going to be the epidermis. Very good. And this is going to be what? The notochord. Primitive knot. Primitive knot forms the notochord. Very important. Yes. And this region here, this is going to be the paraxial mesoderm. We will study more detail in the upcoming slide. Here, this region is going to be the intermediate mesoderm, and this one is going to be the lateral mesoderm. Let's learn a little bit more in the upcoming slide. So when we move towards the transverse section of the embryo, we can see that the paraxial mesoderm, remember the paraxial mesoderm, which is yellowish in color here, this forms the axial skeleton, skeletal muscles, and also somites. Very important to remember. The paraxial mesoderm forms the axial skeleton, skeletal muscles, and also somites. In somites, remember the major components are going to be sclerotome, myotome, and dermatome. Once again, sclerotome, myotome, and dermatome. Yes, the sclerotome forms the vertebrae, ribs, and the rib cartilage. These are all questions. Please study well. Sclerotome forms the vertebrae, ribs, and the rib cartilage. Myotome, as the name suggests, it is going to be the musculature of the back, ribs, and the limbs. Very good. Next, dermatome forms the dermis of the back. Dermis of the back. Next, we have also called the minor component, which is going to be the syndrome, which is going to form the tendons. At least please remember this much. So paraxial mesoderm, axial skeleton. Second, it is going to form the skeletal muscles and all those somites. Somites further classified into paraxial mesoderm, and then they have further classification into sclerotome, myotome, and dermatome. That's it. Now, intermediate mesoderm, very important. Intermediate mesoderm is going to form what? The red one right over here, this forms the urogenital system. Urogenital system. Good. The lateral plate of the mesoderm, it gives derivatives to the appendicular skeleton, smooth, and the cardiac muscles. This region right over here, this is going to give rise to what? Appendicular skeleton, smooth, and the cardiac muscles. CNS embryology, it happens in the 3rd week. Formation begins from the cervical region. 2 points to be remembered. Look at the image here carefully. This is going to be the neural groove. Yes. This is the ectoderm, neural plate, and the notochord. This notochord right over here, it induces the ectoderm to invaginate and form the neural plate and also neural folds. Now, the neural plate, it fuses to form neural tube. The neural plate fuses to form neural tube. Yes. And then the neural folds, they form neural crest cells. They form the neural crest cells. Neural crest cells are going to give different cells derivatives, and neural tube is also going to give various derivatives. We'll study them shortly. So points you're going to remember is going to be neurulation formation of neural tube starts from 3rd week, very important. Yes. Formation of neural tube begins in the cervical region. Yes, we just discussed about it. Next, notochord induces, this notochord induces ectoderm to invaginate and form the neural plate. It's a question, and again neural fold. These are all going to be questions, very important. Next, neural plate fuses to form the neural tube, and the neural folds forms neural crest cells. All of these are going to be questions, and here we can see the neural tube formation. Yes, this is how it's going to be formed. What are the derivatives of neural tubes? It's very important. So, brain and spinal cord, especially astrocytes, ependymal cells, and oligodendrocytes. You have to remember all these cells. Derivatives of neural crests are going to be ganglions, adrenal medulla, parafollicular cells, C cells of thyroid, and also melanocytes, and the conotruncal septum, which is going to be spiral septum and bulbar septum. You have to remember the derivatives of neural crests and also neural tube. All these two are going to be important. Closure of neural pore. This image over here, you might have seen it several times. This is called as anencephaly. Usually the anterior pore gets closed by 25th day. If it does not close, failure of closure of the anterior neural pore by 25th day is called as what? Anencephaly. Yes, very important. This image has been asked several times in the exam. This image over here, this is called as spina bifida. Spina bifida. Yes. Usually the posterior neural pore gets closed by 28th day. If it doesn't get closed by 28th day, it leads to condition called as what? Spina bifida. Yes. Look at this image carefully also. Both the images are very important and frequently asked. This is the case of spina bifida post surgery. Now, what are the types of spina bifida? It is going to be spina bifida occulta, where you're going to see tuft of hairs in this region. Next, this one over here, this is called as meningocele, where you will see fluid accumulations. Fluid accumulations along with neuronal nerve involvement is called as what? Myelomeningocele. Let's revise quickly. We have occulta, meningocele and myelomeningocele. Let's revise the upper limb. This section is going to be very useful for we are going to discuss all the important topics which are commonly asked in the exam. It will not only help you for the exam but also to develop a good concepts in anatomy. We'll be discussing about joints, nerve supply, muscles and also the humerus bones. We'll be discussing about the deltoid muscles, axillary artery, the palmar arches, bones of the hand as well as the carpal tunnel, cubital fossa, rotator cuff and also the major nerves. Let's dive into the upper limb now. Joints. Joints. Since school days we have all studied about joints. Our favorite one all around would be ball and socket joints. For our exam we have to study few more joints. Let's focus on it now. We have three types. One is going to be synovial joint, another is going to be cartilaginous, and then we have fibrous joints. Synovial joint, remember it is movable joint. Cartilaginous, it is partially or slightly movable. Fibrous joints are immovable ones. Yes. Now let's discuss synovial joint in depth. We have plain joint. Example is going to be acromyoclavicular joint, very important. Saddle joint, example sternoclavicular joint, very important again. Ball and socket, our all-time favorite, it's going to be shoulder or glenohumeral joint. Ellipsoidal joint is going to be metacarpophalangeal joint, and hinge joint, example is going to be elbow joint. Please remember all these ones are going to be questions frequently asked in the exam. Cartilaginous joint, slightly movable, they are going to be synchondrosis and symphysis. Like pubic symphysis, these are all going to be partially movable. These are examples of what? Cartilaginous joints, where you can see the cartilages. Next, fibrous. These are immovable joint. There are going to be sutures, syndesmosis and gomphosis. Syndesmosis and gomphosis. So here, this is an example of what? Symphysis, pubic symphysis, and here we can see an example of synchondrosis. Let's look into more details of fibrous joints. Fibrous joints, as we know, it is going to be immovable. Yes, it is immovable because of what? Dense connective tissues being present, and it is made up of collagen fibers. It is made up of collagen fibers, very important. Now look at this region over here. These are going to be what? Sagittal, this is going to be the coronal suture. Now these are going to be immovable. Yes, they are called as what? Fibrous joints, sutures. Next we have syndesmosis. Syndesmosis, remember bones, they are usually joined by ligaments. They are joined by ligaments. Example is going to be tibiofibular joint. This is going to be what? Tibiofibular joint. This is going to be syndesmosis. And here we have radio-ulnar joint. Radio-ulnar joint. This is going to be an example of syndesmosis. Next we have gomphosis. Please remember, it is the joint between the tooth and socket in the maxilla and mandible. Here you can see this tooth which is present between the socket and the maxilla. This is the teeth, and here we have the gum process. Yes. Brachial plexus. This is going to be definitely useful for your life as well. Please concentrate. Now, roots, trunks, divisions, cords, branches. Let's try to remember this first with a very good mnemonic. Mnemonic comes with rugby team drinks cold beverages. Yes, it comes with mnemonic. Rugby team drinks cold beverages. Now, first we start with the roots. Now, C5 and C6, they gives rise to a trunk called as what? Upper trunk. Very good. They give rise to a upper trunk. Very good. Further, they give divisions, which is going to be the anterior divisions and posterior divisions. And then they give rise to the cord, which is called as what? Lateral cord. They give rise to the lateral cord. Very good. And then the branches. Now C7, remember the root value C7, it gives rise to the trunk. As it is in the middle, it is called as middle trunk. Very easy to remember. This is called as middle trunk. Very good. And then again it gives rise to the anterior divisions and also posterior divisions. Now this gives rise to the posterior cord. This gives us to the posterior cord. Very good. The roots of C8 and T1, they give rise to the lower trunk. Very easy to remember. As it is low, it is called as lower trunk. And then again it has the anterior divisions and the posterior divisions. It gives rise to medial cord. It gives rise to the medial cord. We will discuss this in detail. Please don't worry. So this is going to be what? Brachial plexus with a very good image. Please try to revise this. Roots, trunks, divisions, cords and branches. We just studied it. Now let's try to revise this nicely. C5, C6, as we know, they give rise to the upper trunk. Yes. And the anterior and posterior. Now you have to remember the cords. C5, C6, the anterior divisions gives the lateral cord, and the C7's middle trunk anterior divisions gives rise to the lateral cord. All the posterior divisions are going to form the posterior cords. Very easy. And then the C8 and T1 lower trunk anterior division will form the medial cord. If you can practice the diagram, it will become very, very easy. Please draw and practice it. Now, it is important to know what are the branches and what are the muscles they are supplying to. Now, the lateral cord, C5, C6, they supply muscular cutaneous nerve, lateral pectoral nerve, lateral root of median nerve. All these are important ones to be remembered. The C7, it supplies to upper subscapular nerve, lower subscapular nerve, it's just subscapular upper and lower, nerve to latissimus dorsi, axillary and the radial nerve. If you are not able to remember all, it comes to the beautiful mnemonic called as ulnar. Ulnar. So now I hope you can remember this very easily. Beautiful. This comes to the mnemonic M, L, L. Yes. C8 and T1. Now remember this gives branches to medial cutaneous nerve of the arm. It supplies it. Medial cutaneous nerve of the forearm. In simple words, just remember arm and the forearm. And then medial root of the median nerve, medial pectoral nerve and also ulnar nerve. This comes to the mnemonic 4MU. That's it. So if you remember this, you would complete the brachial plexus beautifully, and with the help of practicing diagrams, you will remember it until the exams. Erb's paralysis. It is due to injury to the C5 and C6 nerves. It's very important. I have had an injury and it was really painful. Now, remember, Erb's paralysis is due to involvement of C5 and C6. Yes. Along with that, please remember that the nerves involved in Erb's paralysis are going to be axillary nerve, muscular cutaneous nerve and also subscapular nerve. Let's revise. Axillary, muscular cutaneous and also subscapular nerve comes to the mnemonic AMS. Please remember. Now this is the image of Erb's paralysis. You can see forward rotated shoulder could be seen, upper in the redness of the arm, and also you can see waiter tip or the policeman tip. If you happen to see these images, this is going to be image of what? Erb's paralysis. Now it could be, as we discussed earlier, fall on shoulder, or it could be birth injury. Findings, it's going to be policeman tip, waiter's tip, or also porter's tip. The arm of the patient is going to be adducted and medially rotated, very important. Secondly, elbow is going to be extended, and third, forearm is going to be pronated. So this is going to be very important for the exam. Erb's paralysis. Nerve root involved is going to be C5 and C6. Nerves involved is going to be AMS, axillary nerve, musculocutaneous nerve, and also subscapular nerve. Please remember the mnemonic AMS. Let's discuss Klumpke's and winging of scapula. Klumpke's, remember the word itself as inside U and M. It is due to the injury to ulnar nerve and also medial nerve. First problem is solved. Nerves involved is going to be ulnar nerve and medial nerve. Very good. It is injury to the lower trunk of the brachial plexus. Okay. Next we have C8. Nerve root involved is going to be C8 and T1. Yes, please remember. It can cause hyperabduction of the arm, and the sign can be what? Claw sign. It is going to be having what? Claw sign. Please remember. And also this is how it's going to be. Findings will be medial border of the scapula will be prominent. Yes, claw sign is seen in Klumpke's paralysis. Klumpke, U for ulnar, M for medial nerve. Please remember. Good. Next, winging of scapula. It is due to what? Long thoracic nerve. Please look at the image carefully. Winging of scapula is due to long thoracic nerve. Musculocutaneous nerve. It is a long nerve. Yes. This nerve over here, which you see, this is called as what? The musculocutaneous nerve. It originates from the lateral cord of the brachial plexus. It supplies the anterior compartment of the arm. Very important. Supplies the anterior compartment of the arm. It is going to be coracobrachialis, brachialis, and also biceps brachii. You can remember the mnemonic BBC. Please remember brachialis, biceps brachii, and also coracobrachialis comes mnemonic BBC. Good. Sensory supply is going to be as it continues as lateral cutaneous nerve of the forearm. It continues as lateral cutaneous nerve of the forearm. Musculocutaneous nerve, very easy. Supplies the anterior compartment of the arm. Point number 1 to remember. Next, the nerves are going to be, muscles are going to be BBC. One is going to be brachialis, biceps brachii, and coracobrachialis. That's it. So please remember musculocutaneous nerve. Yes. Next, axillary nerve. It originates from the posterior cord of the brachial plexus. It supplies the deltoid muscles and the teres minor. Yes, deltoid and teres minor. Sensory supply goes to the skin of the upper lateral side of the forearm. Upper lateral side of the forearm. This beautiful muscle right over here, this is called as deltoid muscle. Yes, insertion is going to be at the deltoid tuberosity of the humerus bone. Very good. Nerve supply is going to be axillary nerve. Yes, axillary nerve. Very important. Actions are going to be flexion and medial rotation of the arm. Flexion and medial rotation of the arm, extension and the lateral rotation of the arm, and also abduction of the arm. So flexion, extension, and abduction of the arm, and it's going to be helping with what? 15 to 90 degrees only. Yes. Apart from this, what else you have to remember? Anterior fibers attached to the clavicle, lateral fibers attached to the acromion process, and the posterior fibers, they attach to the spine of the calf scapula. All these are very important. You have to remember the nerve supply. Axillary nerve is the one which is supplying the deltoid muscle. Very important. Yes. Ulnar nerve or the musician nerve. Yes. Now it originates from the medial cord of the brachial plexus. Root value is going to be C7, C8, and T1. You can remember it's 781, something like this. It supplies the forearm. This nerve right over here, this is going to be our ulnar nerve. Now supplies the forearm, middle 1.5 of the muscles of the anterior compartment, flexi carpi ulnaris, and flexor digitorum profundus, especially the medial half. Please remember ulnar nerve or the musician nerve. It is going to be having root value of C7, C8, and T1. This muscle right over here, this has been recently asked in our FMGE exam. This is going to be extensor pollicis longus. When our thumb is pressed, This muscle, extensor pollicis longus, can be palpable and can be visible. Yes. Median nerve. This nerve right over here, it originates from the lateral cord and the post-medial cord of the brachial plexus. Root value is going to be from C5 to T1. Yes, please remember C5 to T1. It supplies all muscles of the anterior compartment of the forearm. Please remember forearm except the medial 1.5. This nerve right over here, this is called as what? The radial nerve. It supplies the triceps muscles. Origin is going to be with the posterior cord of the brachial plexus. Root value again, it is going to be from C5 to T1. So median nerve and radial nerve, that's the reason why I put it together. Root value is going to be from C5 to T1. Supplies the posterior compartment of the arm. Yes, supplies the posterior compartment of the arm, especially triceps. Yes, please remember median and the radial nerve. Two nerves are very important. Axillary nerve. This one right over here, this is going to be the anterior terminal branch of the axillary nerve, and this is going to be the posterior terminal branch of the axillary nerve. Root value which has to be remembered is going to be C5 and C6. Axillary nerve root value is going to be C5 and C6. Yes. Nerves related to the humerus, very important. Nerves related to the humerus bones, three important nerves. One is going to be the axillary nerve. Yes, this nerve. Secondly, we have the radial nerve, which is very important, and then followed by ulnar nerve. Axillary nerve, medial nerve, and the ulnar nerve. These are all the important nerves of the humerus bone. Yes. Bones of the hand. Look at this. This is going to be the carpal bones. Yes, these are going to be the metaphalanges. Yes. These are going to be the phalanges, very important, the basic ones. Next, this is going to be the proximal layer of the carpal bone, and this is going to be the distal one. Now, you have to remember the carpal bones. Let's revise. The mnemonic called as she looks, I think this is a favorite one for everybody. She looks too pretty. Try to catch her. Yes, she looks too pretty. Try to catch her. This is going to be scaphoid. This is going to be lunate, and this one is going to be what? Triquetral. This is going to be the pisiform. Next, we have the trapezium, trapezoid, capitate, and the hamate. Very important. Please revise these carpal bones. Yes. Capitate is going to be the largest carpal bone. Next, we have pisiform. Pisiform right over here is going to be the smallest carpal bone. Most commonly dislocated is going to be this bone right over here. This is called as what? Lunate. Yes, please remember. And avascular necrosis happens in this scaphoid bone. Yes. Good. If you look into the radiological images, which have been also commonly asked, let's look at them carefully. This right over here, this is going to be what? The radius. So right next to the radius is going to be our scaphoid, which is going to be boat-shaped bone. Very good. Now this bone right over here, this is called as what? Lunate, most commonly dislocated. This is going to be the triquetral, and then here we have the pisiform, which is going to be the smallest bone. Next we have trapezium, trapezoid, capitate. We can see it's bigger, the biggest bone, carpal bone. Next, and then we have the hamate. Good. Now I hope you have understood the carpal bones, and please revise them carefully. Carpal bones are also very important for the exam. Nerve supply of the hand. Just put your hands like this and focus now. I will explain with the images shortly, so try to focus. You start with the thumb. 1, 2, 3, 3.5. This 3.5 is supplied by median nerve. I repeat, 1, 2, 3, 3.5. It's supplied by median nerve. The remaining 1.5 is supplied by ulnar nerve, both the front and the back. That's it. Stick to that. This part right over here is supplied by radial nerve, and the posterior part, this 1.5, 3.5, is supplied by radial nerve. I will explain the images. If you have not understood, let's revise carefully now. This hand, this 3.5, starting from your thumb, is supplied by median nerve, and when you change your look at the posterior part, again this from here to this region, 3.5, it's applied by median nerve as well. Now very simple to remember ulna. This is going to be the 1.5, and the posterior 1.5, it is again supplied by the ulnar nerve, and the remaining portion is supplied by the radial nerve. Just look at the image once carefully, you will understand it more easily as well. So no confusions. Once again, 1, 2, 3, 3.5 is supplied by median, 1.5 front and back is supplied by ulna. This region is going to be by radial nerve, and this remaining, this 3.5, this one and this 3.5 is supplied by radial nerve. That's it. Palsies of the hand. Now this image over here, this is called as hand of benediction, is due to median nerve. Hand of benediction is due to median nerve. Claw hand is due to ulnar nerve. I think we have all revised it. Wrist drop is due to radial nerve injury. So please remember these nerve palsies as well. Clavicle is a very important bone. It is a horizontal bone. This joint right over here, this is called the sternoclavicular joint. It is from the manubrium of the sternum and the acromion process of the scapula. Yes, fracture usually happens in the medial 3/5 and lateral 2/5. Yes, at this region. It is the first bone to ossify by 5th week, and it is also the last bone to complete ossification by 25th year of age, and it has no hematopoiesis. Very important point to remember. These 2 points are very important to remember for the exam. Quadrangular space. You're going to put your hands like this. Very good. And then you're going to merge it together and put it like this. Here you can see 2 spaces. One is the square space. I hope you can see it. One is square in shape and another one is in triangular shape. This square shape, it is called as quadrangular space, and this one is called as triangular space. Let's revise it carefully now. Very importantly, you are going to look at this image is called as what? Quadrangular space. Yes, you have to remember the content passing through it. It is going to be the axillary nerve. It comes to the mnemonic AP, axillary nerve, and also posterior circumflex humeral artery. Axillary nerve, posterior circumflex humeral artery. Very important. And it is also required to study the borders. Remember, superiorly it is supplied by the teres minor, inferiorly by teres major. Look at this. Superiorly by teres minor. Very good. And then inferiorly by teres major. Yes, this one. Good. Now laterally by the surgical neck of the humerus. Yes, you can see. And then medially by the long heads of the triceps. Let's repeat once again. Superiorly by the teres minor, inferiorly by teres major, laterally by humerus, and then medially by the triceps, long head of triceps. That's it. That completes our quadrangular space. What is the content passing through? AP. A is for axillary nerve, P is for posterior circumflex humeral artery. Very good. Now, lower triangular space. What are the structure? This region, this is called as what? Triangular space. We are going to study the lower triangular space. Structures passes is going to be RP. R is for radial nerve and also profunda brachial artery. Profunda brachial artery. Boundaries are going to be superiorly teres major, medially long head of triceps, and then the laterally shaft of the humerus. Please revise this. It can fetch you 1 mark as well. Rotator cuff or the musculotendinous cuff. You are going to remember 4 important muscles. One is going to be supraspinatus, infraspinatus, and then subscapularis, and then teres minor. Let's repeat. You are going to remember this muscle right over here. This is called the supraspinatus, and then this muscle right over here. This is going to be infraspinatus. You are going to remember this one right. This is called the subscapularis, and you are going to remember the teres minor. Focus. 4 important muscles: supraspinatus, infraspinatus, we have teres minor, and then subscapularis. Insertion is going to be at the graded tubercle. Most common dislocation is going to be at the anterior, and forgotten muscles of the rotator cuffs is going to be our subscapularis. This muscle is called as what? Forgotten muscle of the rotator cuff. Anatomical snuff box. I hope you can see your own anatomical snuff box. What is the content passing through it? It is called as radial artery. Very good. Content passing through the anatomical soft box right over here. This is called as anatomical soft box. And what is the content? Radial artery. Boundaries are being commonly asked. Laterally there are 2 tendons. One is going to be, this is going to be the lateral tendons. One is going to be extensor pollicis brevis, and another one is going to be abductor pollicis longus. So please remember these 2 ones. Medial tendon right over here, this is going to be extensor pollicis longus, extensor pollicis longus, very good. And then right over here we have extensor carpi radialis longus and also brevis. The floor of the anatomic subbox is going to be scaphoid and trapezium. This is going to be very important. Please do revise your very own anatomical snub box. Axillary artery, it's a very important artery. We have previously discussed that it is going to supply the deltoid muscle. Yes, axillary artery, it is the axillary artery is a continuation of subclavian artery. It is a continuation of subclavian artery, and further it continues as the brachial artery as well. Axillary artery divides into three parts by the pectoralis muscle, So please remember 3 points. Number 1, it is the continuation of subclavian artery. Further it continues as the brachial artery, and then it divides into 3 parts by the pectoralis minor muscle. Yes, look at the image of axillary artery. Branches of the axillary artery is being commonly asked as well. Let's revise them now. Now, as we know, axillary artery is branch of the subclavian artery. Now, it further divides into 3 parts. First part, look at here, it divides into this region. This is called as what? Superior thoracic artery. And the second part, it further divides into the thoracoacromial artery and also into lateral thoracic artery. Beautiful. Next, the third part, it further divides into number 1. You can see it here. This is called as what? The subscapular artery. It further divides into the posterior circumflex artery and also the anterior circumflex artery. That's it. So if you can revise it with the images given, you will beautifully understand it. So axillary artery, please study it well. Very important. Cubital fossa is very important. This region, the triangular depression in front of your elbow joint, is called as cubital fossa. It is very important to remember the content of it. It comes with a simple mnemonic called as MBBS. Yes, let's revise it. It comes with the mnemonic MBBS. Very good. First M is for median nerve, second B is for brachial artery and also biceps brachii tendon, and remember it is all supplied by radial nerve. Superficial radial nerve and deep radial nerve, deep branch of the radial nerve. So it is going to be superficial branch of the radial nerve and also deep radial nerve. Now it comes to the mnemonic MBBS. Median nerve, brachial artery, biceps brachii tendon, radial nerve. That's it, MBBS. Radial nerve, superficial and deep. Now it is important to also remember the borders. Medially it is supplied by the pronator, laterally it is supplied by the laterally brachioradialis, very good. Floor is by the brachialis and then supinator muscles. Yes. Another 2 important points you're going to remember is going to be cubital tunnel syndrome is due to ulnar nerve, and Guyon's canal syndrome is going to be also due to ulnar nerve. Cubital and Guyon's canal is going to be due to the injury to ulnar nerve. Yes. Carpal tunnel. Look at your very own crease right between this part of the hand, and right in the middle is going to be your carpal tunnel. Yes, this is going to be your carpal tunnel. Now there is going to be a transverse carpal ligament which is called as flexor retinaculum. This is called as flexor retinaculum. What are the structures passing superficially to the flexor retinaculum? Ulnar nerve, ulnar artery and the palmaris longus tendon. You can remember with UP, U for ulnar nerve and another U for ulnar artery. Good. Structures passing through the flexor retinaculum. You can see here there is a structure passing through the flexor retinaculum. It is called as flexor carpi radialis. Very important to remember. What are the contents passing to the carpal tunnel syndrome? Again, it is going to be median nerve. Median nerve is going to be passing to the carpal tunnel. Right. You can see here, this is going to be the median nerve. Along with that, you have another 9 more tendons which is passing through the carpal tunnel. It is going to be the flexor pollicis longus right over here. Flexor digitorum profundus, 1, 2, 3, 4, and then again we have 4 flexor digitorum superficialis which are also passing to the carpal tunnel. I hope this has helped you to understand the importance of carpal tunnel, and the injury to median nerve at this region will lead to carpal tunnel syndrome. Thank you, doctors. I hope the upper limb and the embryology sessions was useful. Stay tuned and subscribe to the channel to view more lectures And there's a big surprise coming for you on the way. Stay tuned, and hope to see you guys with happiness and pleasantful preparation for the main exam coming in December. Thank you.